I try to record these so that I can get them put onto MindTap for anybody who's not able to be here. So before we get started today, has anybody been having any issues with MindTap or anything like that you want me to help you through? Anything at all? Problems, issues? Cool. Okie dokie. Well, we are going to pick up right where we left off. We are on page 248 of your Beck book, starting at the autonomic nervous system. This page right here. Okay. So last class we talked about the one main division in the nervous system, which was the autonomic system and the peripheral system, or the central nervous system and the peripheral system. Central nervous system, we said, was brain and spinal cord. Peripheral nervous system was all of the nerves that branch off of that. The peripheral nervous system now, so we're looking at the nerves on the side. This system is divided into two main parts. We have the autonomic and the somatic. So the autonomic, when you hear that word autonomic, I want you to think automatic. It's all the stuff that just happens without us really having to think about it. The autonomic nervous system, highlight in your book, autonomic means self-governing. The autonomic nervous system regulates the actions of glands, smooth muscles, and the heart. It controls circulation of blood, the activity of the digestive tract, respiration, and body temperature. So basically, you guys, it's everything that we can't really control. So we're talking about things that are involuntary. The autonomic nervous system consists of motor neurons that originate in the central nervous system. I just want to make sure that we've clarified this. When we talk about these neurons originating in the central nervous system, so we've got the brain. I'm going to just do a very rough drawing here. We have the brain and spinal cord, and then we have all of the nerves that branch off of the spinal cord. Remember the nerve cell, you've got the cell body and then those long axons coming off of those cells. The cell bodies are in the spinal cord. Only the axon is extending out. So you may have dozens or hundreds of cell bodies, all of whose axons are bundled together, becoming the nerve fiber. So the nerve fibers are just the axons, just the extensions. The body of the cell, the nucleus, the cytoplasm, all the fun stuff that we think about when we think of cells, that stuff is all staying in the spinal cord or right alongside the spinal cord in a structure called a ganglia. We're going to talk about those in a minute, but the bodies of the cells are always hugging the spinal cord. Only the axons are extending out to become nerves, and those axons will be bundled together with connective tissue to become the actual nerve. So the autonomic system, this automatic system that is controlling things without any input from our conscious minds, this system is going to be further divided into two. The autonomic system is divided into the sympathetic system and parasympathetic. And the way I like to just kind of conceptualize the difference between these two, because your textbook will give you a very eloquent, very wordy explanation of the differences between the two, I can summarize all of them up into one famous pairing that you guys will have no problem understanding. The S is for Spider-Man, the P is for Peter Parker. The sympathetic system is the fight-or-flight system. This is the system that is activated when we are under stress. When the adrenaline and the cortisol are released, suddenly our muscle tone increases, our senses heighten, our focus tightens up. We're able to accomplish great deeds when we are under stress. The sympathetic system is responsible for increasing heart rate, increasing respiration. We get the blood moving out to the skeletal muscles so that they become tightened and toned and ready to exert themselves under stressful situations. But once we are no longer in a stressful situation, eventually the situation will calm down, right? We're no longer being chased by a bear in the woods. The boss stopped yelling at us and left the room. Whatever the situation is, it will resolve itself. And now we have to undo all of the things that we just did to the body. We have to lower the heart rate. We have to lower the respiration rate. We have to bring everything back to a sense of homeostasis. That is what Peter Parker does. The parasympathetic system is the system that is active on all of us right now. We are calm, we are safe, right? We're drinking our coffee, or we should be drinking our coffee. When we are nice and relaxed, this is the parasympathetic system at work. So for massage therapists, when we have clients coming to us that are super stressed out, they're living their lives with the sympathetic system activated. By getting a massage, and you've all had a massage where afterwards you felt really relaxed, what that therapist did was activate the parasympathetic system, the Peter Parker system, turning off the Spider-Man system. Is that analogy clear for everybody? Good stuff. So now that we have a fundamental idea of the difference between these two systems, let's jump in our textbooks and read this very wordy explanation. The nerves of the sympathetic nervous system originate in the thoracolumbar portions of the spine between T1 and L2. They enter a double chain of small ganglia. These are masses of neurons. Now, when we talk about this, here's just an illustration when you look in your book. So we see the spinal cord itself, and there will be lots of neurons whose bodies are held in there. But right alongside, we have this double chain. All of these little masses are the ganglia. These are masses of neurons, cell bodies. Remember, only their axons are extending out to reach into the rest of the body to send those signals. The body of the cell is either in the ganglia, right alongside the spine, or within the spinal cord itself. So the sympathetic nervous system supplies the glands, the involuntary muscles of the internal organs, and walls of the blood vessels with nerves that prepare the body for energy expending circumstances. The sympathetic system is the stress system. The sympathetic system is the fight or flight system. This is the division of the nervous system that takes over when any kind of situation arises that requires us to react to that situation, right? So the second some idiot cuts you off in traffic and your heart rate goes up and suddenly you tighten your grip on the wheel, your eyes open real wide, that's the sympathetic system. Once that idiot drives up past, down the road a little ways and we kind of start to calm down, right? We take a few deep breaths. We feel our stress level start to slow down. We have just shifted from the sympathetic back to parasympathetic. All right. So at the top of page 249, the first paragraph, highlight the activity of the sympathetic system is primarily to prepare the organism for energy expending, stressful, or emergency situations. So like we just said, stress time. When we need Spider-Man, sympathetic system turns on, suddenly we can fight the bear or run away from the bear, which is the smarter thing to do. The stimulation of the sympathetic nerves bring about rapid responses. These responses are things like increased respiration, dilated pupils, increased heart rate, and cardiac output. So not only is the heart beating faster, but we're pumping more blood throughout the body. Blood vessels dilate, get larger, so we can get blood into areas more easily. The liver increases conversion of glycogen into glucose for more energy. So glucose is a sugar. We burn sugar for energy, but we don't always store it as sugar. The liver stores glucose as glycogen. It's just kind of like putting your sugar in an airtight jar so you can store it somewhere. And then the liver will convert it back into glucose, so now we can burn it and use it when we need it. Highlight. There is increased mental activity and production of the adrenal hormones epinephrine and norepinephrine. All of these activities prepare the body to meet emergencies. So, excellent explanation from the textbook, but again, nothing that we haven't already kind of conceptualized in our heads from this example. We're already kind of getting a feel for the difference between these two systems. Moving into the parasympathetic system, this one counteracts the actions of the sympathetic. So Peter Parker undoes Spider-Man. The general function of the parasympathetic division is to conserve energy and reverse the action of the sympathetic division. Highlight. The effects of parasympathetic activity are reduced heart rate, respiration and blood pressure, and increased digestion and elimination. We're talking about pooping. The parasympathetic nervous system is most active when a person is calm and in a state of relaxation. So hopefully we are all living our lives, right? We're chilling at our house. We feel nice and safe where we are. Our parasympathetic division is running the show right now. Parasympathetic nerve fibers that serve the organs and glands of the thorax are part of the vagus nerve. Pelvic portions of parasympathetic system arise from the second, third, and fourth sacral spinal nerves. Parasympathetic nerve fibers associated with parts of the head are included in cranial nerves 3, 7, 9, and 10. All right. The main takeaway from this that I want you to, the main idea here is the difference between these two systems. The other thing that I want you guys to keep in mind is that these two divisions belong to the autonomic nervous system. So we've talked now about lots of divisions and other divisions and then subdivisions within the division. So let me give you guys a flow chart of the whole system so we can see where all of these things kind of fit. So we start with the nervous system as a whole, the whole nervous system, right? Nervous system. Two main divisions, central, peripheral. Somebody unmute and tell me what comprises the central nervous system. What comprises the central nervous system? One at a time. Questy, I see you. Brain and...
Spine.
Very good. Brain and spinal cord. That's your central nervous system. The peripheral nervous system, so all the nerves on the periphery, on the side, we have two main divisions. The two divisions of the peripheral system are the autonomic and the somatic. Autonomic means automatic. This is all the stuff that just happens without us having to really do anything about it, right? Heart rate, respiration, digestion, reproduction, all that stuff. Somatic is the voluntary stuff. This is the division that I have control over. So when I decide to scratch my nose or, bust out breakdancing or do yoga or the voluntary stuff. The autonomic division is going to be further subdivided. I don't know if you guys can see. The autonomic division, this automatic stuff, is divided into two. Sympathetic, parasympathetic. Spider-Man, Peter Parker. Fight or flight, stress time, relaxation, chill time. Okay. So again, I know that this is like, what is a lot of stuff, but it does make sense when you think about it in this way, because basically what we've just done is segmented the nervous system into the areas that are responsible for the biggest functions. So brain and spinal cord are really controlling and coordinating everything. But this peripheral nervous system is where we're getting all that sensory information from. Now, if we were going to go one step further, sympathetic, parasympathetic, somatic, we could divide those one more time into sensory and motor. So you've got the sensory information coming into the brain, and then the motor commands coming out of the brain, telling the body how to respond to whatever the brain just figured out is happening. But I think we're good with this. I think we can leave it here. Do we have any questions over this so far? Good stuff. Good stuff. Okay. Okay, so the next thing we're going to talk about are reflexes and reflex arcs. Now, I'm sure everybody is at least somewhat familiar with reflexes. If nothing else, you guys have all gone to the doctor and they hit your knee with that hammer, right? And your knee jerks. When we think about reflexes, we usually think about, how fast can you like catch a ball or something. But when we're looking at the nervous system, reflexes mean something a little different. We're going to use a more technical definition of a reflex. So let's start with we've got our brain and spinal cord here, my very detailed drawing. Okay, so what we have here, and this is super detailed drawing, I know. We've got our brain and spinal cord, and then we have two nerves coming out of the spinal cord and innervating our knee. These two nerves have to be divided because we have one that is sensory, one that is motor. Okay, one is receiving information and feeding it to the brain. The other is carrying the brain's commands out to the knee. So when your doctor strikes your knee with that little reflex hammer, he is providing a stimulus. So you strike the knee with the hammer, that information is sent along the sensory nerve fiber into the spinal cord. But a reflex doesn't involve the brain. Most reflexes are actually mediated at the level of the spinal cord. So the brain doesn't make the decision to kick the knee once you strike it with the hammer. The spinal cord does it automatically. The response to the stimulus is a motor command causing your quadricep muscle to contract. And you guys who have done muscles, when the quadriceps contract, the knee extends, it straightens out. So we send a stimulus into the spinal cord. The spinal cord provides a motor command, which is carried along the motor nerve fiber into the knee. The quadriceps contract, the knee kicks. Now, what we have just described from the nervous system standpoint is a stimulus and a response that was carried to the brain using one pair of nerve fibers, one sensory, one motor. It did not take the whole nervous system to respond to this. This was a very basic function, right? One stimulus, one response using one pair of nerve fibers. That is a reflex. That is what we mean when we use the technical term of a reflex. We are talking about a stimulus and a response that was dealt with using only one pair of spinal nerves, one sensory, one motor. Good stuff? Okay. So, under reflexes and reflex arcs in your textbook, I want you to highlight the first sentence. A neurologic pathway or a neural pathway is the route that the nerve impulse travels through the nervous system. Stop highlighting there. The usual nerve path consists of a stimulus, that would be like the doctor hitting the knee with the hammer. It initiates an impulse along a sensory nerve fiber to the spinal cord, communicates with an indeterminable number of interneurons. So we have no way of really knowing how many neurons were involved in this. We would have to do really sensitive brain scans, and that's just beyond our scope. So we'll just say we have no idea. It works with some number of interneurons within the brain and spinal cord. But then, depending on how complicated or intricate the response, finally a response impulse is sent along motor nerves to the associated effectors, producing the resultant action. The effectors are whatever that motor nerve is connected to. So any motor nerve, whatever that nerve is connected to, that is its effector, right? Just like wherever the muscle is attached, that's its insertion. Same thing. Whatever the motor nerve plugs into, that's the effector. So it could be a muscle, it could be a gland, it could be skin, whatever it is. So, highlight. The simplest form of nervous activity that includes a sensory and a motor neuron and few, if any, interneurons is called a reflex. The nerve pathway of a reflex is the reflex arc. Now, when we talk about nerve pathways, again, it's easy to make this more complicated than it really has to be. Guys, this is a relatively simple concept, and I like to explain it using a common analogy. Now, you younger guys may be a little too young for this, but anyone who is my age or older will remember the days, the dark ages before iPhones, when we needed directions, we had to use MapQuest, and you had to like put in the directions on your computer at home and then print them out, right? And then carry that paper in the car with you like some kind of caveman. So when you look at those MapQuest directions, it gives you step-by-step directions, right? You travel 200 feet on this road and then turn right. And then you go for 5 miles down that road and then you turn left. And it gives you step-by-step directions to take this map of the roadway and find your way from point A to point B. If we were to take MapQuest directions for where that stimulus began, right? In this case, it was the knee. We follow the exact sensory nerve, not in general, the nerve that signal took to find its way into the spinal cord. And then we find the nerve, not one of a group, the exact nerve, the exact pathway that the motor command took to leave the spinal cord into the knee to create the action, right? If we had these MapQuest directions to know exactly which nerves carried that signal, that direction, that MapQuest directions, that's the reflex arc, okay? So if we were talking about a very complicated action, like you step in something, I feel something on my foot, now I have to stop, balance, bend my knee up and really like look at the bottom of my foot, that's a complicated system of actions. That would be like having MapQuest directions that are 2 or 3 pages long because there is multiple things going on. There are a lot of stimuli, right? Because it's not just the feeling on my foot. Now I have to balance and I have to adjust my muscle tone to maintain my balance. I've got to bend multiple joints. I have to contract multiple muscles in order to look at the bottom of my foot. That is a very complicated action. Those MapQuest directions are going to be pages and pages long. With a reflex, we are talking about the equivalent of MapQuest directions from your front door to your mailbox. This is a simple direction, right? Point A to the spinal cord to point B. Boom. If anything, a reflex arc, if you're going to translate it into a MapQuest page, should be like 3 steps. Like walk to the driveway, turn around, walk back to your front door. A very basic direction. That is the reflex arc. It is the pathway that that signal took from the point of the stimulus to the spinal cord back to the effector, whatever it is we're going to make do something as a result of the stimulus. Is that clear for everybody? Good stuff? Good stuff. So again, what we just explained, I'm going to recap with the textbook. This is the simplest form of nervous activity. A reflex is as basic as it gets. We are talking about a form of nervous activity that involves one sensory neuron, one motor neuron. Very few, if any, interneurons in the brain or spinal cord. This isn't something we really have to think and cogitate about and come up with a plan and recognize patterns, right? You stick your hand on a hot stove, bicep contracts, you pull your hand off the hot stove. Done. That is a basic stimulus, basic response. This is as simple as the nervous system can get. So, this example that we've been talking about is called the knee jerk reflex. You strike the patellar ligament just inferior to the patella. You strike it with a hammer, it causes the quadricep muscles to contract and the knee jerks. But there are many, many, many other reflexes. The withdrawal reflex or the flexor reflex, you could think of it as the hot stove reflex. You place your hand down on something hot, you immediately register the stimulus, it's too hot. Your brain will contract the bicep, which is an elbow flexor, hence flexor reflex. The bicep contracts, the elbow bends, and we pull the hand away from the hot stove. All of this happens like that, right? You don't have time to think about, oh, is the stove too hot? I'm not sure. What should I do? Your nervous system takes over. You contract that bicep, you bend the elbow, you pull the hand away. The thing about reflexes is they are usually mediated, like I said, at the level of the spinal cord. So the brain is not making the decision to contract the muscle or bend the joint. The spinal cord does it automatically. The brain is informed after the fact of what had just happened. This is why you don't get a chance to think about it. Reflexes just happen, right? You don't think about the hot stove. Sometimes you haven't even felt the heat yet. You just pulled your hand back like a reflex, right? Your brain had no input in the reflex. It is informed after the fact of what the body just did. Most of the reflexes are dealt with by the spinal cord. Now, there are a lot of other reflexes that are in the body. Babies have tons of reflexes that they grow out of as they develop. Anyone who has ever had kids or dealt with babies, I mean like very, very young, very small babies, if you put your finger in their hand, what does a baby do? Exactly. And aptly enough, this is called the grasping reflex. It comes from the time when humans had a lot more fur. So when you took a newborn baby and were climbing through trees or something, you stick that baby on your furry back, it reflex kicks in and it's holding on to your back fur. So these babies, you could stick them on your back and they would just hold on using that crazy strong baby strength. And the reflex that they developed of just, you put something in their hand, they hold on to it, right? It's good for survival when you're a wandering herd of people that have a lot more fur and don't have free arms to carry babies with. Another reflex that babies have is called the suckling reflex. If you put something into a baby's mouth, they will suck on it. That is what babies do. Again, it's a useful instinct to have when you're brand new. You don't have to be taught how to eat, right? You just innately know how to eat. But over time, these reflexes will be grown out of. You will lose reflexes as you age. And then as you get really old, like into old age, even these basic reflexes will start to slow over time. And this is one of the reasons why you're just not as sharp as you were when you're elderly. A lot of your reflexes have kind of dulled. Hold on, I've got a caller one is Chelsea Marcinek. Thank you. Thank you for that. Hold on, let me make a note real quick. Caller one is. Thank you guys.
Dave, this is Lois. Dave, this is Lois. I've been on it too the whole time.
Okay, are you caller 2?
I don't have anything. I can't see what you're saying. Maybe.
Okay.
I've been on too, but I just had a recall. This is Chelsea.
Coral can't get in.
Coral can't get in?
Yeah. She says she sent you an email.
Let me check my email. Give me 1 second. Let me pull up the links and resend it to her. I don't know why she can't get in. I'm sorry about the interruption, you guys. Give me 1 minute. Okay. I just emailed her the link again, so she should be able to just click on the link and open it up. We'll see how it goes. Okay, so okay. So does anyone have any questions about reflexes or reflex arcs? So the reflex itself is this action that happens, right? You strike the knee with a hammer, the knee kicks. That's the reflex. The reflex arc is just the pathway, those MapQuest directions. Which exact nerve did the signal take to get to the spinal cord and from the spinal cord? So if we were talking about something more complicated, like the example I gave you a moment ago, you step in something, you feel it on your foot, so now you got to balance and coordinate as you bend your foot up to see what's on the bottom of it. I said if we were going to list those directions, those MapQuest directions would be pages and pages and pages long. That would be the neurological pathway. That is what we would term that. The route that the signals take to complete something is a neurological pathway, but a reflex arc is the neurological pathway of a reflex. These instructions are usually very simple, very basic, right? Take 20 steps to your driveway, turn around, take 20 steps back to your front door. Reflexes and reflex arcs, reflex arcs and neurological pathways are the same thing. We're just talking about, with reflex arcs, the neurological pathway of a reflex. It's usually going to be very much shorter, very simple, because there isn't a whole lot of, there really isn't a whole lot of extra things to do. You're talking about a very, very basic function. Okay. Any questions about autonomic nervous system, sympathetic, parasympathetic, reflexes? Okay. So then we're going to move right along to page 250. We are looking at neurological disorders. So everything that we have talked about so far with the nervous system has been, hey, Coral, good to see you. Glad you made it. So everything we've been talking about so far with the nervous system has been assuming that everything is working according to plan. We are assuming that everything is structured the way it's supposed to be, development was normal, there's no disease. We've been learning about the system as it should work. But you learn a lot of stuff about an organ system when you watch how it fails, when you watch what happens when it doesn't work correctly. It tells you a lot of information about what's going on in the system when you see the system not work the way it's supposed to. So the first one that we're going to talk about is multiple sclerosis, also called MS. Multiple sclerosis is relatively common. There are a lot of people that suffer from this disease. But ultimately, the cause of multiple sclerosis is autoimmune. With autoimmune diseases, as we know, your immune system, for some reason, decides that tissue within your own body is the enemy now, and we just go ham trying to defeat the enemy. Every autoimmune disease has selected some different type of tissue. So with rheumatoid arthritis, for example, it's attacking synovial tissue in your joints. So all synovial joints are fair game for rheumatoid arthritis. With multiple sclerosis, the tissue that has been marked for death by your immune system is the substance myelin. Where have we heard myelin before? Oh, wasn't myelin that fatty material that insulated nerve fibers or something, right? It was myelin was that material that insulated a nerve fiber in much the same way we insulate power cords. So what's going to happen to a nervous system whose wrapping of the nerves is suddenly under attack by the immune system? Well, the immune system will cause inflammation, and the constant attack will eventually cause the myelin to break down. But remember, the body heals itself, right? So no big deal. But remember, the body heals with scar tissue. And scar tissue is awesome, but scar tissue is not myelin. It doesn't do the same things, right? Myelin was fatty. Scar tissue is made of collagen. Strong, tough, but it's not fatty. It's not good at insulating. So as we envision this nerve running through the body, this nerve is under attack by the immune system. The inflammation is triggered, the myelin sheath breaks down, the body heals with scar tissue, but scar tissue cannot do the job of myelin. So what happens is these signals that are being sent through the nerve, they don't reach their destination. Some of those signals can leak out in the same way that if you had a frayed or ruptured power cord, if you touch it to the ground, your laptop will like short out because the electricity isn't reaching its destination. The same kind of thing happens. If the wrapping of the nerve fiber degrades or transforms into scar tissue, then the result is that nerve signal doesn't reach its destination. And you guys know at this point, as well as I do, if a muscle does not get the signal to contract, it doesn't contract. So we term this loss of function, right? The muscle doesn't contract when we want it to. You've lost function in the muscle. So, highlight, multiple sclerosis, or MS, is a degenerative nerve disease that affects the body's ability to control the muscles. Now let's look at this word, because the word tells you something. The name of the disease is telling you something. Multiple sclerosis. The ending, osis, that suffix indicates a condition. So whatever we are naming, it ends in osis, we are naming some kind of condition. Well, what kind of condition? The root of this word sclere or sclero means scar tissue, right? Or a thickening. Multiple tells me it's not just one scarring or one thickening. There are multiple scarrings or thickenings going on in this condition. So multiple sclerosis is a condition of multiple scars. What happens is as the immune system attacks the myelin sheath of your nerves, the myelin sheath heals with scar tissue, leaving scars or sclera along the course of the nerve fiber. These points where the scar tissue is present, the nerve is weaker and the integrity of that nerve signal is starting to be lost. And if it progresses, you lose more and more of that nerve signal. Eventually, not enough of the signal is left. I'm going to be a little technical, so we got to throw back to muscular system. But if too much of the nerve signal is lost, there isn't enough signal to trigger the threshold of that muscle, the contraction threshold. If the signal isn't strong enough, the muscle fails to respond. So it doesn't contract. So you don't move. You have lost function. Multiple sclerosis usually occurs in young adults. The onset is usually between 20 and 50 years of age. It is a result of the breakdown of the myelin sheath that surrounds the nerves, which inhibits nerve conduction. Symptoms vary from minor to debilitating. Like all autoimmune diseases, some people have very mild symptoms. Some people drastically lose function. On the more mild side, you just get more weakness, more fatigue. There's some muscle aches and pains, but you manage. Multiple sclerosis also comes in spells or waves. So there will be flare-ups where it's really bad, and then it goes away for a while. And then it flares up again, and then it goes away for a while. Some people will have one bad flare-up and never have a symptom again. Some people have multiple bad flare-ups that just stack one on top of the other, and they lose a great deal of function. The progression of the disease is very individual. Symptoms include muscle weakness, spasticity, that is having muscle spasms, and loss of coordination or balance. The loss of bladder control. Remember, your bladder is both voluntary and involuntary, right? There is a involuntary part, which is why babies wet themselves, and then there is a voluntary part that we develop through potty training. So if you lose the voluntary control through multiple sclerosis, then you lose bladder control. Speaking becomes difficult. Remember, muscles are involved in speaking. Vision is affected. Remember, the iris of your eye is a muscle, right? Controlling the aperture of your eye. So if you're losing muscle control, your eyes can't focus like they should. So you start to lose vision. Patients can experience memory loss and difficulty concentrating. The progress of the disease varies with periods of remission and then exacerbation. So it comes in spells. There are flare-ups to this disease. A person can have an episode, totally recover, never have another episode again. Another person could have one attack after another and end up being very debilitated. We do not have a cure for this disease. We don't have a cure for any autoimmune disorders. All we can do is treat symptoms as they arise. So we can treat pain, we can treat inflammation, we can treat, things like that. But the underlying cause of the disease is the immune system. And we do not have the knowledge or technology or the medical knowledge to tweak somebody's immune system that way. If you do research and you figure out the cause of autoimmune diseases, dude, publish your results, you will win a Nobel Prize. Because if we know the cause, we can create a cure. We don't have it yet. But we do know that certain medications to relieve symptoms combined with physical therapy and massage can help stave off some of the worst effects, right? Physical therapy and massage will help keep circulation in muscles. They help keep the muscles stretched and toned, and can help counteract some of those worst effects of the disease. So there we have multiple sclerosis. The next one we're going to talk about is Parkinson's disease. Real quick, before we move on, I like to give a famous celebrity example for these diseases because every one of these neurological diseases, there is some famous person that you know that has this disease. Multiple sclerosis, the most famous person is, I forgot his name. Montel Williams, the talk show host, right? He's had multiple sclerosis for years, and he has been an advocate for years about the use of medical marijuana to treat his symptoms. This has been his fight for like 20 years. But he's been suffering from multiple sclerosis for a really long time. All right, the next disease we're going to talk about is Parkinson's disease. Now, Parkinson's disease, as you've noticed, this one isn't a medical term. It is customary in medicine to name a disease after the first diagnosed patient. That's where we get Parkinson's disease. Parkinson was the first guy that was diagnosed with this condition. But usually they will also be labeled. You have the common name like Parkinson's, and you would have the medical name. I'm not going to lie to you guys. I don't know the medical name. We all just know it as Parkinson's. So we're going to move right along. Highlight. Parkinson's disease occurs as a result of the degeneration of an area of the cerebrum which produces the neurotransmitter dopamine. That is it. That is Parkinson's disease. Your brain stops making dopamine. Doesn't sound like such a big deal, but dopamine is a neurotransmitter, and neurotransmitters are kind of a big deal to the nervous system. That's like how things get done in the nervous system. So without dopamine, another nearby area of the brain loses the ability to balance the control of agonists and antagonists. So think about this. One part of the brain stops producing dopamine, but as a result of that, another part of the brain needs dopamine to make sure that prime movers and antagonists stay in balance. If prime movers and antagonists are not in balance, we cannot coordinate muscle control. We can't coordinate our muscles to do complicated activities. This results in a lack of coordination and a difficulty in moving experienced by those afflicted with the disease. This is where those tremors come into play, right? The characteristic tremors of Parkinson's disease, because the agonists and antagonists aren't in balance anymore. They keep firing. So if you keep firing flexors and extensors, you end up with a tremor. It usually develops later on in life. You usually don't see younger people afflicted with it. It's characterized by tremors and shaking, especially in the hands. Muscles stiffen as movement slows and movement becomes more deliberate as postural reflexes are lost. So suddenly, right, if you're pushed over, your postural muscles react to bring you back to an erect posture. But again, if agonists and antagonists are no longer balanced, even a slight push, you fall right over. So you're very uncoordinated. Balance is an issue. As gradual rigidity of the muscles increases, especially in the flexors, right? So flexors are going to be on the anterior side. So when these guys get tight, it pulls you into a stooped posture. So one of the characteristics of Parkinson's is that Parkinson's posture. And a labored shuffling gait. So we're not able to coordinate our legs. So instead of lifting each foot with each step, you kind of slide your feet, right? So you slide your feet in this stooped posture and your hands are shaking. Changes in your vocal cords will affect your speech until pretty soon you're barely able to whisper. Because of the progressive nature of the disease, when we're talking about diseases, guys, progressive means it just gets worse. It doesn't get better, right? If it got better, it would be an acute condition. If it's only going to get worse, it's degenerative or it's progressive. It is usually accompanied by anxiety and depression, as any of us would be depressed if we were slowly losing control of our own body. But one of the other key symptoms to this disease, I want you to make a note in the margin or somewhere, Parkinson's is also associated with memory loss. Because, surprise, surprise, dopamine is also used in the incorporation of long-term memory. So you've got a really fun thing going on. You're losing control of your body because you're missing this neurotransmitter, and also you can't remember shit. So you've got a lot of memory loss on top of all of the other symptoms that you've got brewing. And the famous celebrity example of Parkinson's, I'm sure some of you guys have probably already beaten me to it, is Michael J. Fox, right? You guys may know him as Marty McFly. He's the guy from Back to the Future. But the actor, Michael J. Fox, has Parkinson's disease. The next condition on our list to look at is amyotrophic lateral sclerosis. That is a very fancy word, and you should use it in a sentence one day. It's very fun to say. Amyotrophic lateral sclerosis has a couple of other names. It's also abbreviated to ALS. This is the disease that everybody was doing the ice bucket challenge for a couple years ago, right? Everybody's dumping ice buckets on their head and then nominating friends. The purpose of all of that was to raise money for ALS research. Another name for ALS is Lou Gehrig's disease. Again, Lou Gehrig was a baseball player. He suddenly lost control of his pitching arm. He went to a neurologist and they were like, something really weird is going on with your nerves and we don't know what it is. So you, Mr. Lou Gehrig, you have Lou Gehrig's disease. Welcome to medicine. Highlight, ALS or Lou Gehrig's disease is a progressive and eventually fatal neurological condition that causes the motor neurons of the brain and spinal cord to degenerate and die, causing weakness, spasticity, atrophy of the voluntary muscles. Now, the important thing to note here, guys, they specifically said motor neurons. Motor neurons are affected by ALS, not sensory neurons. In my opinion, this is my personal opinion, ALS is one of the more sadistic diseases that humans are liable to have. And I use the word sadistic to mean this is a disease that inflicts suffering for the sake of suffering. These people are slowly and progressively losing control of their bodies. They are losing control of their ability to move, to speak, to blink. And as a result, they are becoming more and more every day prisoners within their own body. But their sensory neurons are not affected, which means they are in there. They are fully aware of what is happening to them. Their brains are functioning normally. They can feel your touch. They can smell your perfume. They can hear your voice. They are fully aware of what is going on around them. But as their body betrays them and they lose control, they have no ability to respond to their environment. They can't speak when they're in pain. They can't push someone away that they don't want near them. They can't express their love to a loved one who's taking care of them. They become locked in their own head, locked in with their own thoughts, fully aware of the outside world, utterly unable to interact with the outside world. It is a heartbreaking condition, and one of the worst diseases, in my opinion, that human beings have. If somebody were in pain, a great deal of pain, usually we would allow euthanasia or physician-assisted suicide or something. We would let that person die with dignity. But ALS, they're not in pain. They're not suffering in the physical sense. Their suffering is almost exclusively mental because they are locked in their heads and they're unable to interact with the outside world or with their loved ones. Or it's a very, very tough disease. It's a very tough disease. ALS usually attacks people between the ages of 40 and 60 generally. But these things happen on a bell curve. So 40 to 60 is at the height, but you will have some people that are younger and some people that are older when they get diagnosed with this condition. It affects nearly twice as many men as women. So by far, men are more likely to contract this disease. And as the disease progresses, it starts with weakness or twitching in a leg, like a leg or arm or hand. It eventually moves into slurred speech. And then depending on which nerves are actually involved, muscles throughout the body will soon become involved. You start to lose your ability to speak and move and swallow. You eventually lose the ability to breathe on your own. Remember, guys, diaphragm is a muscle and it controls breathing, and it's a voluntary muscle. So if you're losing control of the motor neurons, you don't have control of breathing anymore. And not just the somatic side, you guys, this is the autonomic side as well. Your brain loses control of keeping the lungs breathing. So even though you are fully conscious and fully aware of what is happening to you, you have to be put on an artificial respirator because you don't have control over your breathing anymore. It has to be done artificially, which is terrible. We do not have a cure for ALS. All we can do is manage symptoms at this point. 50% of the people that are diagnosed die in 5 years. 90% of people succumb within 10 years. Usually the cause of death is complications due to paralysis or the loss of respiratory function. So ALS only attacks motor neurons. It does not affect your sensory system. So eyes, ears, taste, tongue, your sense of touch, all of these are perfectly intact. It doesn't affect memory. So make yourself a note, there is no memory loss with ALS. Parkinson's there was. ALS, you got all your memories, you got all your marbles. All your marbles are in here. You just lose all voluntary and involuntary control over your body. And the famous celebrity example of ALS is the physicist Stephen Hawking. He was the scientist in the wheelchair. He had the little computer chip linked to him. He only retained control of one facial muscle. So he would twitch, and you can see a very faint twitch in his eye that would trigger a cursor on his screen. So he had a list of every word in the English language, and he would have to scroll down the list and select a word, and then scroll down the list and select his next word. So when he was giving lectures, because he was a professor, when he was giving lectures, it would take him hours to compose his lecture. He would get all the words together and then select play, and his machine would read the entire speech that he had prepared, but he wasn't able to just answer questions on the fly because composing a sentence took several minutes. He had to select one word at a time. Brilliant scientist. If you guys aren't familiar with Stephen Hawking's work, a lot of people knew who he was, but what he did, being locked in his head, he did the math in his head that predicted black holes. We all know about black holes. He was the one that came up with the idea and then proved it mathematically that these things should exist. And how do we find them? They should emit a special kind of radiation. And if you find this radiation, you found a black hole. So we turned our telescopes up to the sky and we found the radiation. So we proved the existence of black holes, and then we named that radiation Hawking radiation. When you discover something in science, you get to name it, and they usually name it after themselves. But Stephen Hawking did all of this in his head. All of the math and everything, he did it in his head, which just, I can freaking divide in my head. Like, I have to have a calculator for everything. This guy is doing like complicated astronomical equations in his head. I can't even begin to describe that kind of genius. I don't have it myself. But Stephen Hawking has cemented his name in science because he accurately predicted a very weird physical event. Like, black holes defy all the rules. And he not only gave us rules for how black holes would develop, but also gave us a way to find them. And we did, which is huge. Okay. Stephen Hawking is in my heart, you guys. All right. The next one we are going to talk about is a spinal cord injury. This is often shortened to SCI, spinal cord injury. Highlight. A spinal cord injury is caused by trauma or disease to the vertebral column or to the spinal cord itself. So most of these injuries that occur cause some kind of pinching or tearing of the spinal cord, which of course will affect the function of the spinal cord. The injury affects the ability of those nerve fibers in the spinal cord to relay information either to the brain or out to the body. So this results in a loss of sensation and movement, sensory and motor. You lose sensation and function in a particular area of the body. Now, the important thing to keep in mind, again, here's my beautiful, complicated brain and spinal cord. We have C1, C2, C3, yada, 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 T1, T2, blah, 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 L1, L2, blah, 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 blah. If there is damage to the spinal cord, you guys go closer. If there is damage to the spinal cord, you will lose sensation and function. God damn it. There we are. Whew. I lost you guys for a second there. Whew.
Well, hear him and see him.
I can see some of you guys. The connection, this connection got really bad. I can still see some of you guys though. Can you guys see me? Have no signal. There we go. I can see you guys again. Can you guys, I can see a couple of you guys. Can you guys hear me okay? Give me a thumbs up if you can.
Yeah.
Okay.
Yes, I can hear you.
Internet, sorry about that. Guess we just decided to take a break for a minute. Okay. So, as we were saying, if the spinal cord is damaged at some level, right? So right now, let's just say T1. You will lose sensation and function everywhere below the site of the injury. Above the site of the injury, everything is still normal. So you're good up here. But everything below the level of injury, you will lose function. So when we look at a chart like on the previous page and we see how the spinal cord is linked to every organ and organ system, if you draw a line somewhere, everything below that line, you lose function. This is why some people can suffer a spinal cord injury and they just lose function of their legs, right? But their arms and neck and everything work fine. Other people break their neck and they lose everything from the neck down. You lose all function below the site of the injury. So if we, I believe that we already highlighted the first sentence, a spinal cord injury is caused by trauma or disease to the vertebral column or to the spinal cord itself. Pause highlighting, skip down towards the center of that paragraph. I really want you to highlight and circle and underline below the site of the injury. You lose function below the site of the injury. Everything above the injury still functions normally. So every spinal cord injury is different depending on exactly where the damage was, how bad the damage was the damage only on one side of the spinal cord or both sides? It just depends. So injuries in different places can cause different types of function loss. And we name these, there are different types of paralysis. So give me a moment, I'll draw some of these out. See if you guys can see this. That was good enough. So with a condition like this one, the arms are still functioning, but you've lost function in the legs. This is known as paraplegia. Paraplegia means a paralysis. So para is telling you two. You've lost 2 limbs. Here, we have lost function in all 4 limbs. This is known as quadriplegia. 4 limbs have been lost. Quadriplegia. If the spinal cord is damaged in a certain way, you could keep function on one side but not the other. I'm talking about an injury that cut the spinal cord like this. You would have more function on this side and less function on this side, just because of the sheer amount of the nerve fiber, right? You have all this nerve fiber left over here, not enough over here. This could result in a situation where you lose function in one arm, but keep function on the other arm. This is what we see here. One arm is still good, this arm is paralyzed, and both legs. This is known as tetraplegia, literally 3 limbs. And then another interesting one that happens sometimes when people have a stroke. So when they have a stroke, part of their brain is damaged. Remember, the brain is split into hemispheres, and each hemisphere controls the opposite side of the body. Like I'm doing the Macarena here. So the left side of the brain controls the right side of the body. The right side of the brain controls the left side of the body. So if one half of your brain has a stroke, you damage the brain, you lose function, but the other half is fine, you will become paralyzed on the opposite side from the side that was lost, right? So my left hemisphere is fine, my right side is fine. My right hemisphere was damaged, my control of the left side is damaged. Here we see that. These limbs are paralyzed, these limbs are fine. This is known as hemiplegia, literally half paralyzed. So there we've got the 4 general categories of paralysis. Paraplegia, what we would call waist down, you basically lose function from somewhere in the abdomen down. Quadriplegia, from the neck down, you lost all functioning, you're just a head at this point. Tetraplegia, you've lost 3 limbs, but you will usually retain control of one arm. Remember, you can't retain one leg because you lose everything below, and the arms are above the head. So if you've lost an arm, you've lost the legs. Everything below the side of the injury is lost. Hemiplegia, usually with a stroke, not a spinal cord injury, but with a stroke, you lose half, right? Because the brain controls each half. So we're going to move down to the last part of this paragraph. Highlight the last sentence. An SCI is a complete injury when there is no motor or sensory function below the injury level. The injury is incomplete when not all the spinal nerve fibers are affected and there is still some sensory or motor function below the site of injury. So again, the spinal cord, you could damage it and it still functions. This would be like a small tear or a bruise to the spinal cord. But if you sever the spinal cord and it's cut and that's it, then unfortunately, guys, that's it. Remember, nerve tissue doesn't heal the same way. And if it does, it heals with scar tissue, which is not nerve tissue, so it cannot do the same thing that it was doing before. Nerve tissue is unique and it's special, and you only get what you get. And it doesn't heal like muscle or bone or epithelial tissue will, unfortunately. Lately, there has been some successes with the use of stem cell therapies to help with paralysis, but we're still really in the early stages. That's not anywhere near a legit treatment just yet. So, good stuff. So the next condition on our list to talk about is a stroke. Everybody's heard of a stroke, but the medical name for a stroke is a little trickier. It is a cerebrovascular accident. What we are saying is there was some kind of accident or disruption in the blood flow of the cerebrum. So a part of the brain lost blood supply, and then that part of the brain then died, as things do when they lose blood supply. There are two things that can generally cause a stroke. That would be the obstruction of blood, like with a blood clot, or with the loss of blood, like with an aneurysm. Right? When the aneurysm bursts, you've got a hole in the vessel, all the blood is leaking. With a blood clot, the blood flow stopped. The river dries up, and now everything downstream dries out and dies. So highlight the first sentence: a stroke or cerebrovascular accident is the result of a blood clot or ruptured blood vessel in or around the brain and the subsequent destruction of nerve tissue. So guys, a stroke is the third leading cause of death. It is only behind heart disease and cancer. It's like heart disease, cancer, stroke. Top three things that kill Americans. The effect of a stroke, just like with a spinal cord injury, it is very individual. It depends on exactly where in the brain the damage happened, exactly how extensive was the damage, and since everything in the brain, we say that functions in the brain are highly localized, which means specific parts of the brain do very specific jobs. And they don't talk to each other, right? So if this part of your brain does language, this part of your brain does actual speech, like the physical act of speaking. But this part of your brain remembers all the words. And this part of your brain thinks about what would I say if this situation happened. So with functioning in the brain being highly localized, so specific parts do specific things, it really depends on exactly where the damage is to know what kind of function you lost. How will your recovery go? Well, if you had a stroke in the part of the brain that recognizes faces, well, your spouse may not be too happy about it, but you'll live. If you had a stroke down in the brainstem, the part of the brain that controls heart and lung function, you may not survive it. So it just really depends on exactly where and exactly how bad the damage was. So every stroke is different. Often a stroke causes, as we said a moment ago, paralysis on one side of the body. The paralysis will be on the opposite side from the brain where the damage occurred. You may lose vision in one or both eyes. You may lose your ability to speak or your ability to understand language. Remember, language and speech are different things, right? Reading words is not the same thing as speaking words. And these two functions are separate and held away from each other in the brain. So you may lose your ability to talk, but you still hear English and understand it. You may lose your ability to understand language at all. You could also experience a loss of memory because, I don't know if you guys do this or not, but memory is stored in the brain. So if you do damaging your memory files, the memory files become corrupted, and we don't have a way of rebooting this computer. When those files are corrupted, they're gone. I don't have a thumb drive I can stick in your ear and re-upload your memories. Damage to the brain is usually permanent because we don't have the knowledge or ability to fix it or to heal it or to restore function. Once the brain is damaged, that's all we can do is just manage symptoms, right? Put you in therapy, speech therapy, physical therapy. But if it's lost, unfortunately, most of the time, you guys, it's lost. And there's really nothing we can do. We just help that person cope and help them move forward. But there's really nothing we can do to the underlying condition to try to treat the actual condition. The extent of their paralysis will be related to the extent of neurological damage. So a tiny stroke, you may lose a tiny bit of function. A massive stroke, you lose massive function. Good stuff with strokes. We're making good time. Moving on, we are looking at epilepsy. On page 253, epilepsy, I want you to highlight the first two sentences. Epilepsy is a neurological condition characterized by abnormal electrical activity in the brain without apparent tissue abnormalities. This is a really important point. When we do scans on the brain, nothing is wrong. Structurally, the brain looks fine. We look at blood flow, we look at electrical conductivity, we look at the structure, we look at the anatomy. Everything checks out. But this brain, for some reason, just has these electrical activities where all parts of the brain are firing at the same time, and we have a seizure. Epilepsy is characterized by seizures, some of which are so mild you may not even notice. Some are so extreme that the person is thrown onto the floor in these heaving, convulsive fits. People with epilepsy generally will live normal, healthy lives because we have medications that can stop seizures. So most people can be put on medication and then they don't have seizures, so they can live a normal life. But finding the right medication then becomes the challenge. There's dozens of different medications and they don't work for everybody. So you got to start playing medication roulette as you just try different drugs to see which one finally works. I know for the patient, it feels like the doctor is just throwing you on one pill after another. But guys, you got to understand that's what medicine is. Every body is slightly different. And the drug that works wonders for one person may be ineffective or even harmful to another person if they have an allergy or something. So I know we feel sometimes like the doctor doesn't know what he's doing. He's just throwing pills at me. That's what medicine is. That's all we can do is try this medication. Doesn't work, try this one. That didn't work, try this one. And then eventually we will find a drug that stops your seizures with few side effects. And that is the drug we keep you on. But if I gave each of you guys the exact same drug for seizures, it would work beautifully for some of you, and for others, it would do nothing or make it worse, or you'd have all these side effects. I mean, there's no way around it, you guys. That is how medicine is done. That's what it is. It's not a doctor not knowing what he's doing. That's a doctor following protocol. That's what we do. For clients with epilepsy, it is only contraindicated when they are actively having a seizure. So, if a client starts having a seizure on the table, stop. But, stop. But if they have epilepsy, but they're not having a seizure, or they're on medication, you're good to go. You do a massage as normal. All right. So everything we have been looking at previously has been some kind of structural defect in the brain, something the brain itself isn't doing right. As massage therapists, we are only looking at physical diseases of the brain. We are not looking at mental diseases, so personality disorders and like bipolar. We're not going to talk about all that stuff. That's psychiatry. We're looking at neurology. We are looking at physical, structural changes to the brain, not functional changes like what a psychiatrist would study. So everything we've talked about so far has been some kind of abnormality with the brain, right? Some kind of trauma or disease function. The next few things we're going to look at are infections. What happens when a bad guy gets in? How can a bad guy disrupt function of the brain? The two most common bad guys are viruses and bacteria. So forgive me for jumping right in, but we're going to be looking at viral and bacterial infections. Starting with polio. Highlight, poliomyelitis, or polio, is a crippling or even deadly disease that affects motor neurons of the medulla oblongata and spinal cord, resulting in paralysis of the related muscle tissue. So, symptoms of polio. Starts with a fever because there is an infection, so it triggers an immune response and you start running a fever. Gastrointestinal discomfort, stiff neck as these muscles start to swell, your neck gets kind of stiff, and a headache. If detected early, we can minimize, right? We start treating early, we can deal with it, but post-polio syndrome, like after your body has cleared the infection, Post-polio syndrome can recur for months or even years or decades after the initial infection, and it causes degenerative muscle weakness and fatigue. Now, one of the lasting side effects of a polio infection is the lasting paralysis. This brain infection, if you lose function, you lost it. It's gone. So if the medulla oblongata is affected and you lose control over your voluntary muscles, you don't usually get that control back. You remain paralyzed. You remain paralyzed. You guys, this is a bacterial infection, right? It's a bacterial infection. We can, or I'm sorry, viral. But we can vaccinate now, right? We can vaccinate against polio. So we don't see people dying of, remember, voluntary muscles includes diaphragm. So part of the paralysis means you lose your ability to breathe. That's why the polio victims were put in those iron lungs, those huge metal cylinders they just have their head sticking out of. That was an artificial respirator back in the 40s. Like that, they had to keep them breathing. And you would see polio victims with their shriveled, twisted legs. They'd be walking around on crutches. This was an epidemic that you caught an infection and you develop these symptoms. This is why it's one of the diseases that we vaccinate against. You guys, polio did not go away. It's still around. We just don't deal with it because most people are vaccinated. It's one of the reasons why this anti-vaccination movement is so harmful. Anti-vaccination movement, guys, do not give it any credence. These people are not versed in science. They are not epidemiologists. They are not immunologists. They do not know what they are talking about. They have a PhD from the University of Facebook. Vaccinations are absolutely essential for the health and well-being of a population of people. I'm going to get off that soapbox, but vaccinate your kids, you guys. All right, encephalitis. Encephalitis is another condition. The ending tells you something. Itis. What is being inflamed? The encephal refers to the head or the brain. So encephalitis is literally a brain inflammation. The brain becomes infected and swells. Highlight, encephalitis refers to several related viral conditions that cause an inflammation of the brain or meninges. Symptoms include headache, fever, disoriented behavior, and often seizures. Serious cases can result in nerve or brain damage and can result in paralysis, emotional disturbances, or death. Weird stuff happens to the brain when things start to break down, like personality and memory, weird glitches start happening when the brain is infected. But one of the bigger issues with encephalitis is the brain happens to be encased in a skull. So it's in a fixed container. So as this brain starts to swell, it will grow larger than its container and it creates pressure. Guys, we don't have fancy Star Trek technology. In Star Trek, they just shine a funny light on your head and everything magically goes away. In the real world, the current treatment for that kind of condition is they have to drill a hole, remove a piece of the skull to relieve the pressure. If you don't, you can suffer permanent brain damage. If you do get it in time, they relieve the pressure off of the brain, it can help. But encephalitis, it's a viral infection. It is also crazy, crazy contagious. So anyone that has this kind of condition, they're going to be kept in a secure ward in the hospital. They will not just be roaming around, going into your spa. They will be dealt for with very strict medical people because that stuff is crazy contagious. If there's an outbreak of encephalitis at a college campus, they shut down the dorms. They send everybody home. Like that's it. It is too contagious to allow for the risk of liability. The next condition is very similar, kind of related. It is called meningitis. Highlight, meningitis is an acute inflammation of the pia and arachnoid mater around the brain. So here we are not looking at the brain being inflamed, rather the meninges are becoming inflamed, right? The lining of the brain and spinal cord become inflamed, which again puts pressure on the brain as the lining swells and bears down on the brain. Usually meningitis is a secondary infection. So while your immune system is busy fighting infection A, meningitis arises as infection B. We're usually looking at bacteria that travel from nose, upper respiratory, ear infections that make their way into the inner ear or into the brain. Symptoms include severe headache, stiff neck, high fever, chills, delirium, and often convulsions, which is like seizures or coma. Antibiotic treatment is usually effective. So meningitis is bacterial. Antibiotics work on bacterial infections. Antibiotics do not work on vaccines, like polio. That's why you got to get a vaccine for it. Antibiotics won't have any effect. If it is untreated, meningitis can lead to brain damage, which usually results with possible blindness, deafness, retardation, or paralysis. Severe symptoms can result from meningitis. Again, which is one of the reasons why we need people vaccinated. Vaccinated. Okay, I'm getting off the soapbox for real, I promise. The way we diagnose the difference between encephalitis and meningitis is through a procedure known as a lumbar puncture, or an LP, also called a spinal tap. They put you on a bed, you go into the fetal position, and they take a really long needle and they stick it in the spine in between two bones where the spinal cord is visible. They slide it in the spinal cord in between the dura mater and the pia mater. So you're talking about a space millimeters wide that they're taking this long needle and jamming it in your spine, trying to hit a point that is millimeters wide. Then they pull out some of the cerebrospinal fluid. They extract the fluid, they look at it under a microscope. When you look at it under a microscope, you are physically like seeing the bacteria that are in there. So you can visibly look and see that's an infection. I see the bacteria. If there is a invader present, it will be everywhere. So where it doesn't matter where you pull the fluid from, the fluid is a continuous unit, right, around the brain and spinal cord. So if it's in one space, it's in all those spaces. So you pull some spinal fluid, you look at it under a microscope, you can visually identify the infection. But if you've never had a lumbar puncture before, they really, really hurt. They are not comfortable at all. And that needle is scary big. Like that needle is so freaking big. Okay. Good stuff on everything else so far? Okay, we are almost done. We're going to move on to shingles. All right, highlight the first 3 sentences for me. Shingles is an acute inflammation of a nerve trunk and the dendrites at the end of the sensory neurons caused by the herpes zoster virus. Symptoms include a band of pain around the torso and a rash with water blisters that erupt in a confined area on one side of the body. Seldom does the rash cross the midline of the body. Stop highlighting there. Shingles can develop from an exposure to herpes or chickenpox viruses as a reaction to a medication or trauma. So the thing with shingles, we generally think of it as a skin condition because its outward sign is a rash, usually on the torso, usually in a band that goes from the spine around the front, and very rarely does it cross the midline. It usually stops and stays on one side. The reason for this unique rash is it is not a skin condition. It is a nerve infection. The nerves at the spinal cord are infected. The nerve root, let's say T1 or T7, is infected. The result is the rash that shows up at the end of that nerve fiber. This is why we had to take a moment and point out the other day that bit about dermatomes. So whatever nerve root is infected, that dermatome on that side of the body will bear the rash. This is also why shingles rarely crosses the midline. You need both nerve roots to be infected. in order for the rash to connect on both sides. It is more likely that you infect adjacent nerve roots, so the rash gets bigger on one side, than it is for it to cross the spine and affect its opposite neighbor. They're just too far apart. So more often you will see adjacent, side by side nerve roots infected if the infection is going to spread. Shingles is also crazy contagious, and the rash is very painful. So we say shingles is totally contraindicated for massage. Do not touch them at all. The reality is they won't want to be touched. They are in a lot of pain, and the last thing they are going to want is someone rubbing over their painful, blistery rash. They are going to stay at home or they're stay in the hospital. It's not likely that you're going to see a patient with shingles. We do have a shingles vaccine. So if you work in the healthcare field, or you work with the elderly, or you work with immunocompromised people, it is recommended that you get the shingles vaccine. All right, I'm staying off the soapbox. Neuritis is the next one. Now, neuritis, the name is beautiful. Tells you everything you need to know. Neuritis, nerve inflammation. Neuritis is inflammation of a nerve. Highlight, neuritis literally means inflammation of a nerve. Neuritis is not a disease, but is a symptom of some other condition, usually like a herniated disc or shingles, herpes zoster, or diabetes mellitus. Neuritis affects the nerves of the peripheral nervous system because most peripheral nerves are both sensory and motor. Neuritis can cause weakness or paralysis, and it can be painful. The pain associated with neuritis is called neuralgia. Literally, we break that word down. Neur means nerve. Algia means a painful condition. Neuralgia, a painful nerve condition. Generalized neuritis can affect several nerves. This is polyneuritis, multiple nerve pain condition, or a single nerve, which is called mononeuritis, one nerve inflammation. Neuritis can be caused by nutritional deficiency, so your diet is crap, so your functioning is crap. Alcoholism, chemical poisoning, allergies, infections. I mean, lots of different things could cause it. Usually, remember, this is a symptom, not a condition. So usually the neuritis will subside when the condition subsides. So if you treat the main condition, the neuritis will go away. The neuritis is a symptom of that condition. One of the most common, well-known conditions of neuritis is sciatica. So if you've heard of sciatica before, that is neuritis. It is just neuritis of one single huge fat nerve. That sciatic nerve is huge, you guys. Most nerves are just thin strands of tissue. The sciatic nerve at its thickest is about the size of your pinky finger. That is a big freaking nerve. And when it gets pressure put on it, just like every nerve, if you guys have had any anatomy lessons with me at all of my students will tell you nerves do not like to be touched. They do not like to be touched or pressed or compressed or impinged or squeezed or in any way have any pressure put on them. If you do, they hurt. So, the condition of sciatica specifically is caused by tension in the piriformis muscle. That is why to treat sciatica, we do the piriformis technique. You put your elbow in the hip and you move the knee around. But there are other types of neuritis that we are commonly asked to treat. Sciatica is just the big one. Another one that is of particular interest to us is called thoracic outlet syndrome, or TOS. A very similar process is happening. So with sciatica, we've got a piriformis muscle. It is tight, and that tension puts pressure on the nerve. With thoracic outlet syndrome, the same thing is happening, it's just in a different place. With thoracic outlet syndrome, highlight, It is caused by compression or entrapment of the brachial nerve plexus and or blood vessels going to the arm. This results in pain, paresthesia, numbness, or weakness in the shoulder, neck, and arm. One new word in there, paresthesia. That is the pins and needles feeling, like when your arm is going to sleep. It's like that weird, tingly, kind of static feeling, or your arm just feels kind of stiff and bloated. Like when your arm goes to sleep, that's what we're talking about. So the muscles that are generally responsible are going to be the sternocleidomastoid, or this SCM muscle, and the scalenes. So as these scalenes on the lateral neck, those nerves and blood vessels are running through the scalenes, through these strip muscles. As these muscles become tight, they clamp down on the nerve and on blood supply. And anything that puts pressure on a nerve is going to hurt. So you get pain and numbness, tingling, going all the way down the arm. The way that we would treat it, think about the way we would treat a piriformis release. You put pressure on the muscle and you change the muscle's length while maintaining pressure to reset the muscle tone, and then you stretch it out so that now there's better blood flow and that muscle has loosened up. Same story. So you work on the neck and shoulder, upper trapezius, SCM, scalenes. You put pressure, you stretch the muscle under pressure, right? You change the positioning as you maintain pressure, and then you stretch it out. You increase circulation to the area, you loosen the muscle tension, you will restore function. Another similar condition is carpal tunnel. So highlight, carpal tunnel syndrome is the result of compression of the median nerve. Super important. Highlight, underline, circle it, make a note, point arrows to it. Carpal tunnel is one nerve, the median nerve. That is it. That is the only nerve that is responsible for carpal tunnel disorder. The median nerve runs through the anatomic tunnel of the wrist, causing pain and weakness in the thumb and first 3 fingers. This is the thing about carpal tunnel. Your hand is innervated by 3 different nerves: the radial nerve, the ulnar nerve, and the median nerve. The radial nerve innervates the entire dorsal side of the hand. All of this is radial nerve. The ulnar nerve does these 2 fingers and the medial side, remember anatomical position, the medial side of the hand. So these 2 fingers and the medial side, ulnar nerve, right? It's on the ulnar side. The first 3 fingers and this side of the hand is the radial nerve. This nerve passes through the anatomic tunnel. I don't want to throw too much at you guys, but the anatomic tunnel of the wrist is made between the hook of the hamate and the scaphoid tubercle. Those 2 bony landmarks create little bumps. We cover that bump with a ligament called the transverse carpal ligament, because it is transverse over the carpals and it's a ligament, so transverse carpal ligament. But that, you see that depression, and then we cover the tunnel with a ligament. We've left ourselves with a little hole. That is where we feed that median nerve through. So through repetitive movements like typing or like lifting weights or whatever you're doing, people that drive a lot get it, where you're holding on the steering wheel. But the compression in that joint shortens the ligament, tightening the carpal tunnel, squeezing the nerve. And what do we know about nerves? They do not like to be touched. So when you put pressure on the median nerve, it hurts. But it only hurts where the median nerve innervates. This side of the hand, first 3 fingers. The medial side of the hand and the back of the hand are not affected. No symptoms. There is a quick, simple diagnostic test for carpal tunnel. Now remember, we cannot diagnose. That's not a thing. But I can do a test and know in my head and treat, right? I can do that. So the technique we use to test for carpal tunnel. The carpal tunnel is here. Look closely. These little bracelet rings, these little wrinkles on your wrist, You got to go past those. You got to be in that crux right at the palm of your hand. That is where your carpal bones are. Right. Use a stiff finger and you're going to apply a good pressure. Give it a good solid poke. Poke, 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 poke. Nice and firm. You want a good poke. Did that hurt? If you felt no pain, you are negative for carpal tunnel. Good job. But if you poke on that wrist and it hurts, positive for carpal tunnel. So, do we have any questions over anything that we have gone over these last couple of days? We covered a lot of material, but remember, we don't need to know everything about the nervous system. We need to know the basics. How does the system work? What are the major divisions? What are the major organs? And I think we did a good job covering all of that stuff. But I want to open the floor up to you guys. Do we have any questions or anything that you want me to re-explain or anything?
The only question that I do have is like when it comes to neuron, it's afferent neurons, but it also said sensory nerve. Is there a difference between in like the notes or whatever? It asks for definitions of the sensory neuron and then the sensory nerve, and I'm like, are they the same?
The
I mean,
only
one
thing
is like a bunch, right?
Yeah, I wouldn't focus too much on the difference. When we say sensory neuron, we are talking about one cell. When we talk about a sensory nerve, we are talking about a bundle of axons from many sensory neurons. So whether we're talking about the nerve as a whole, or are we talking about one cell that is in that nerve? But generally speaking, it doesn't really matter. Generally, we're kind of using them interchangeably, unless we're talking about a condition, right? One cell will not have a condition. The whole nerve will have the condition, a sensory nerve. Any other questions? Guys, I'm an open book. Now's the chance. You've literally got me to yourself.
I have a question.
Yeah.
In the meetup, we have the PDF with the cranial nerves. What are we supposed to do with that one? Like,
oh, is that the one with the face?
Yes.
I just hand that out. It's just a handout I give to students. So I just wanted you to read it, look at it, laugh. The purpose of that, so remember each cranial nerve has a number, right? So cranial nerve number 1, we put a 1 in the middle of a piece of paper. That's the nose. It's the olfactory nerve. It gives you a sense of smell. Cranial nerve number 2 is the optic nerve. It is again a sensory nerve. It hooks up your eyes, gives you a sense of vision. Cranial nerve number 3 is the oculomotor nerve. It moves the eyes up and out. So we put like eyebrows, 3s above the 2s. Cranial nerve number 4 is the trochlear nerve, and it moves the eyes. So we get little 4s, I think on the medial sides. It moves them inward and down. So we put 4s right there. So we're building a face out of the numbers to help learn where the functions go. Cranial nerve 5 is the facial nerve, so the whole face. So the whole face gets a 5. Cranial nerve number 6 is, oh God, abducens nerve. It also moves the eye. You get 6s on the lateral sides, like where your tears come from. Cranial nerve 7 is facial nerve. So the 7, you frame the face with 2 7s. Cranial nerve 8 is the acoustic nerve. It's your hearing. So you put 2 8s where the ears go. Cranial nerve 9 is the hypoglossal. G, glossopharyngeal. nerve. So that goes where your mouth goes. Number 10 is the vagus nerve. Vagus nerve is responsible for swallowing, and it goes down all the way down to the heart. So 10 goes down there, the vagus nerve. Cranial nerve 11, some spinal nerve, spinal accessory nerve. It controls like upper neck and shoulders. So your 11s go where your neck and shoulders go. There's an 11. There's an 11. And then cranial nerve 12 is the hypoglossal nerve under the tongue. So here's the mouth. You stick out the tongue, and there is your 12. So there are your 12 cranial nerves mapped out literally by number onto the face. Let me turn this down a little bit, make sure you guys can see the whole thing. So 1, 2, 2, 3, 3, 4, 5, 6, 6, 7, 8, 9, 10, 11, 12. So that worksheet that was there, there's nothing for you to do so much as it's just a way to help remember the cranial nerves. You very well may get cranial nerve questions on the NBLEX. So you need to know name, number, function. Cranial nerve 1, the olfactory nerve, function, smell. Cranial nerve 2, name, optic, function, vision. Cranial nerve 8, acoustic or auditory nerve, function, hearing. Those are sensory nerves, pure sensory nerves. 3, 4, 11, these would be mixed nerves. Right? They are sensory and motor combined. That was the other thing you'll need to know. Are they sensory, motor, or both? And I have a really complicated mnemonic device to remember whether they are sensory or motor or both. But you know what? We got nothing but time, and I kind of have you as a captive audience. So I'm going to talk you through it. Your textbook has a chart that lists all of this stuff out when it talks about sensory or motor or both. Your textbook and I disagree. Listen to me, not the book. One day we'll have a beer and I'll explain to you what my issue is. But for right now, just accept what I am telling you. The book calls all of them mixed nerves. They're not mixed nerves. There are sensory, they are motor, or they are both. Your book and I have issues about what we call a mixed nerve. Your book and I disagree. Starting with cranial nerve number 1, some say marry money, but my brother says big business makes money. So 1 through 12, sensory, sensory, motor, motor, both. Motor, both. Sensory, both, motor, motor. Runs down the list just like that. Some say marry money, but my brother says big business makes money. So cranial nerve number 1, the word up here is some say marry money, that is a sensory nerve. Cranial nerve number 2, the optic nerve, sensory nerve. Cranial nerve number 3, the oculomotor, that is both. I'm sorry, it's motor. It moves the eyes. It's a motor nerve. Cranial nerve number 5. This would be, I believe, the trifacial nerve, cranial nerve number 5. It is sensory and motor. It moves muscles of the face, but also provides sensation. So it's both. Remember, both, we could also use the term mixed. It's a mixed nerve. But if we're using M for motor, we don't want to use M for 2 things, so we stick with both. Good stuff? Some say marry money, but my brother says big business makes money. I have another mnemonic device to remember the names of them. I'll give it to you real quick. Again, this is not a nice, cute, rhyming, pretty, but it's stuck in my head and it's the one I use, so. You guys see all that? All right, so here we go. To name the 12 cranial nerves. On old Olympus, towering tops, a Frenchman and German viewed some hops, like hops. We're talking about the plant here, like what you make beer out of. So, on old Olympus, towering tops, a Frenchman and German viewed some hops. Not the most nursery rhymey of the mnemonic devices, but olfactory, optic, oculomotor, trochlear, trifacial, abducens, facial, acoustic or auditory, glossopharyngeal, vagus, spinal accessory, hypoglossal. So with these two phrases, on old Olympus, towering tops, a Frenchman and German viewed some hops. Plus, some say marry money, but my brother says big business makes money. You put them into a table, you line them up next to each other. I know the name, I know the number, and I know it's either sensory or motor or both. So now all I need to know is the function, and the trick with the function, guys, is in the names. Oculomotor. Oculo means eye, motor means move. Oculomotor moves the eye. Acoustic or auditory, optic, olfactory, glossopharyngeal. Gloss or glosso means tongue. Pharyngeal refers to the throat. So glossopharyngeal, literally tongue and throat nerve. Facial nerve goes to the face. Spinal accessory, it's on the side of the spine, helping with neck and shoulder movement. Hypoglossal, below the tongue. It innervates the floor of the mouth. So, and it helps with swallowing. Good stuff? Yeah! All right. Nobody ever told you that nervous system was hard. And if they told you it was easy, they lied to you. All right. Any other questions? Anything I can answer? You guys got me virtually one-on-one, so pick my brain. One at a time, you guys, one at a time. Okay.
Are these videos recorded so we can watch them again?
I am recording this one. I will get it posted to MindTap.
Oh, great. Thank you.
Yep.
Was last week's recorded?
No, I forgot.
That's okay.
I'm sorry.
It's okay.
But I'm going to try to get better at getting them recorded and just put on MindTap just so that you can watch them. I can't give you credit for it after the fact, but you could still get the lecture and get the explanation and the information. But all of you guys that are attending these live sessions, I'm entering these in the computer as makeup hours. So completing the assignments on MindTap gives you your scheduled hours, and then attending these will give you makeup hours.
Okay.
and I'm trying to do my best to keep track of them all. But I've got 3 classes that meet twice a week, so I've got 6 sessions that I'm trying to track throughout the week, on top of keeping up with everybody's grades. And then we still have students that are just now enrolling into online, so I'm trying to make sure that they're taken care of. I'll tell you one thing, I certainly am is busy. I am still very busy. But the most important thing to me is that you guys are able to keep moving forward. I know that some of you guys are having to repeat lectures or lessons that you've done before, but I have every Sun State massage student from both campuses. I had to figure something out, and I just didn't have the time to come up with individual plans for everybody. So you know what? Level 1, level 2, level 3. Here we go. Everybody fall in your bucket. We're going to move right on ahead. And some guys may repeat something, but blame it on the Rona. So,
This is Chelsea. I just want to make sure that you had me logged in for today.
Chelsea Marcinek. Yes, ma'am.
Yes. All right, cool. Thank you. I just want to say thank you for doing this for us.
Oh, it's my pleasure. It's my pleasure. This is what I do. This is what I'm best at. This is my thing. Yeah, give out an opportunity to do my thing.
Yeah.
No, I'm really glad that you guys are still participating. It really means a lot to me to know that we've got students that are still wanting to move forward and learn, that you guys aren't just like, well, there's a virus, I'm just gonna stay involved. Like, it's important, that you guys are still moving forward. You're keeping your brain active. If any of you guys have ever taken a break from school, anatomy stuff leaves your brain fast. Like, you forget this stuff so fast. And coronavirus or no, you guys are still gonna have to pass the MBLEX. I would much rather you, even if you're repeating something, keep it fresh, keep studying, keep your brain involved with it, because those students that just went on a leave of absence, when they come back, guys, they are not still up to date on this stuff. You would be surprised how much information you just forget, and it happens fast. So you guys all have my deep personal appreciation for your participation in these live lectures. I'm being very patient with everybody as far as, questions and submitting assignments and stuff. I know that we just threw this stuff online and threw you guys into it, but if you guys have any questions, please reach out to me. I'm more than happy to answer questions, work with you any way I can. I've had several students that were late. I'll change due dates, to get you the time you need to get your stuff turned into me. I'm not trying to be a Nazi. Now is not the time to be one of those teachers. Now is the time for some flexibility, patience, compassion. I will give all of those to you if you just give me a little bit of patience and understand I've got a ton of students from both campuses. So I have students I've never even met before that I'm trying to respond to and answer questions. So just keep being patient with me. And if you need anything, you have any questions, any problems, reach out to me. You guys look on MindTap. You've got my phone number. You've got my email address. Just get in contact with me. I'll get back to you as soon as I can. If you text me at 10 o'clock at night, I will not respond. I will get to you the next day, but I will get to you as soon as I possibly can. Okay. All right, guys, it's 12 o'clock. Last chance. Last chance. Any questions?
Nope. Just want to say Happy Easter.
Happy Easter. All right. Well, you guys enjoy the rest of your afternoon. I will see you guys on Tuesday, 10 a.m. And before this week is out, I will email you guys the links for next week's GoToMeetings. I will also post those links in MindTap. In that same section, it says GoToMeeting links. I'll be updating that every week with the links. So you can either find it in MindTap or check your email. I'll get it out to you guys by the end of this week. Good stuff.
Thank you.
All right, you guys stay, wash your hands. See you guys soon.
Thank you.
Bye-bye.